Good evening. Welcome to EMS 210 Emergency Pharmacology. This is your lecture on congestive heart failure. And when you get up in the morning and you try to log into Blackboard, you'll see that the lecture hopefully will record this evening, and I won't have to record it 3 times like I did last week. We're going to use the slides out of the Jeffrey Guy module because I feel like they are succinct and they say exactly what needs to be said. You'll notice in your reading assignment, you're referring back to your Mosby text, page 311 to 315, just like you did for the last lecture, because all of these medications that were mentioned in the previous section are relevant for congestive heart failure. We're also going to revisit ACE inhibitor medications and the renin-angiotensin-aldosterone system. All of these things that we've been talking about in pathophysiology are completely relevant to congestive heart failure. So your learning objectives. You need to be able to explain the concept of polypharmacy in treatment of congestive heart failure. You need to explain the function of diuretics, discuss drugs used for initial management of congestive heart failure like Lasix, morphine, and nitroglycerin, and discuss digoxin and its use in long-term management of congestive heart failure. I'm going to talk about angiotensin converting enzymes, those inhibitors, beta blockers, and calcium channel blockers in treating patients with congestive heart failure. So to start, some statistics for you. Congestive heart failure is increasing in prevalence, and at the time that this book was printed, there were roughly 5 million cases in the United States of heart failure, and roughly 500,000 new cases are diagnosed each year. Those numbers have climbed since the publication of this book. As a paramedic, you're going to be called to assist patients who are often taking multiple medications. This is called polypharmacy. If you've never heard that term before, it doesn't mean multiple pharmacy use. Polypharmacy means the administration of many drugs at the same time. And sometimes these drugs, as we know, can potentiate each other. They can negate the effects of medications, or they can cause untoward or undesired effects, especially in a patient with congestive heart failure. Some of these things can even culminate in death. So congestive heart failure can be the result of ischemic heart disease, and as we talked about before, ischemic heart disease means basically that there is decreased or no blood flow to a portion of the heart, so that portion of the heart is no longer appropriately. The muscle has been starved for oxygen, so it's either damaged or dead. Also, congestive heart failure can be caused by diabetes. Diabetics have neuropathy, and they also have a tendency for ASCVD. And if you don't know what that is, ASCVD, that's atherosclerotic coronary vascular disease, hardening of the arteries, which can also limit muscle perfusion. Hypertension is something that can contribute to congestive heart failure, as well as heart valve disease like mitral valve prolapse or vegetation growing on the heart valves. The onset of heart failure can be acute, like after an MI, or it can take years to develop. And heart failure symptoms are listed here: accumulation of excess fluid, poor peripheral perfusion, or inadequate oxygen delivery to the tissues. This is your patient here with fluid overload. You'll notice the patient will have distended neck veins, pulmonary edema, and swollen ankles. this is congestive heart failure. There's literally nowhere else for the fluid to go, so it starts to back up into the lungs. Your patient will probably have shortness of breath from pulmonary edema, along with extremity edema, especially in the lower legs, because gravity is going to pull the fluid down there. Poor output of the heart caused by heart failure results in an accumulation of fluid in the lungs. So you may hear wet lung sounds when you do an assessment on your patient with CHF. Shortness of breath can be caused by either CHF or by COPD, and CHF is not easily diagnosed by physical exam. Roughly 20% of your patients are going to have no symptoms, and close to half of them will only have trouble on the exhale. So that's important to note, trouble on the exhale. Management for CHF, long-term control is going to be, let's get that blood pressure under control. So your patient's probably going to be maybe on a beta blocker for medication for blood pressure. Patients with CHF a lot of time take medicine for treatment of high cholesterol as well, because remember I said ASCVD, that is one of the things that they're commonly diagnosed with, and that's hardening of the arteries. And here we talk about, again, ACE inhibitors, angiotensin converting enzyme. Do you all remember the renin-angiotensin-aldosterone system? So we have a chemical release of angiotensin that converts to angiotensin 2. And remember, angiotensin 2 helps with fluid balance in your body. So if we're taking a medication that is an angiotensin converting enzyme inhibitor, an ACE inhibitor, it means it prevents angiotensin from becoming angiotensin 2. And people who take ACE inhibitors typically have been diagnosed with ASCVD, diabetes, or high blood pressure. A lot of these people receive medications to control their heart rate and also maybe for thyroid disorders. Management for these patients, first thing we need to know is, do they take multiple medications? Are they being treated for more than one thing? Is this patient a polypharmacy patient? A lot of medications used for treatment in CHF can be harmful for patients who have heart valve disease or with diastolic dysfunction. Okay, and your diastolic number is your lower number in your blood pressure. Immediately when you have a CHF patient, you're going to give them some oxygen. Remember, we want to titrate that oxygen. Not everybody gets high flow O's. We want to make sure we maintain an oxygen around 94%. So whether that's with 2 liters nasal cannula or with a non-rebreather, you make that determination. Probably we're going to give them some Lasix, and a good rule of thumb, if they are not prescribed Lasix at home, go ahead and give them 40 milligrams, but you need to understand it's going to take up to 20 minutes to take effect, so we're going to have to do something in the meantime while the Lasix takes effect. Also, a good rule of thumb, and again, you'll want to clear this with your medical director, if they're already prescribed 40 milligrams of Lasix at home, you may want to double their dose IV. Because if they're taking it on a regular basis, it may need more than just that 40 milligrams IV push. Remember, with Lasix, it actually works in the kidney, in the loop of Henle. Furosemide is a loop diuretic, so through second pass in the kidney, it will cause permeability of the cells to shift so that more sodium enters the cells, thereby causing more water to enter the cells and leave the exit system. So causes sodium to leave the cells, thereby pulling water out and flushing it through the system. So furosemide changes the permeability of cells and capillary membranes so that sodium leaves, and when sodium leaves, water will leave with it. So you have to watch these patients. Okay. Let me go back here. I just want to say one more thing about this. Lasix works really well for reduction of pulmonary edema. We already said it decreases absorption of water in the kidneys. It also increases urine production. I want to say it also decreases intravascular volume because of that cell permeability shift and that sodium shift, sodium leaving the cell. Okay, so with nitroglycerin, the purpose of nitroglycerin is to produce vasodilation. It'll dilate your veins to a greater magnitude than it dilates the arteries, and that results in less blood returning back to the heart, so you have less preload. Because you have less preload, you're going to have less work that the cardiac muscle is actually performing, which means the cardiac muscle itself is using less oxygen. Nitro is one of those things that can give your patient a little bit of relief while you're waiting on the Lasix to take effect. It reduces cardiac workload on your patient with acute symptoms of CHF, and that's important to differentiate the acute symptoms from the chronic symptoms, okay? Nitro will improve blood flow to your ischemic heart muscles because that they're suffering because of the CHF. And we already know, I already told you, nitro gives vasodilation. It dilates the veins more than it does the arteries, and that's how the less blood flow comes back. That's how we have less preload. Now, morphine. Morphine is used with your CHF patients and pulmonary edema patients to relieve pulmonary congestion by venous dilation. And remember how that works, venous dilation? It releases histamine, right? Don't forget that. Morphine also lowers myocardial oxygen demand, and it reduces anxiety in your patients. So that's how that works. Now, digoxin, on the other hand, digoxin increases cardiac contractility, but it also slows down the heart rate. So your heart is pumping less times a minute, but the pumps are more forceful than before. Dig is one of those medicines that's used in patients who have chronic AFib, and it has a therapeutic index of 1 to 1, which means half the time it'll work, half the time it hurts worse. Your heart is going to beat stronger and slower, so it's not necessarily saving oxygen demand on the cardiac muscle. So the benefits of a drug-induced reduction of a heart rate include decreased myocardial oxygen demand, an increase in stroke volume, an increase in cardiac output, a prolonged diastolic coronary blood flow. And that's important. That's important because we need to have our perfusion more effective. Remember, we're going to talk again about ACE inhibitors. Lisinopril is one of those common ACE inhibitors that you're going to see in the field. When angiotensin is inhibited, which by the way, it's the most powerful vasoconstrictor in the body, it's even more powerful than norepinephrine, and that's important for you to know. When angiotensin is inhibited, the most powerful vasoconstrictor in the body halts. It comes to a screeching halt. So your patient then is going to present with a decrease in blood pressure, and they're going to have an increase in urine output. Lisinopril, in combination with other medications, will reduce cardiac ischemic events, reduce mortality rates, and reduce hospital admissions. And that's important for you to know. These ACE inhibitors are really good drugs in combination with other medications. Now, with metoprolol, remember we said all drugs that end in a lol are normally beta blockers, right? Metoprolol is cardioselective beta blocker. So if it works on cardiac beta receptor sites, it's a beta 2 affinity, okay? It binds to beta adrenergic receptors. It will decrease the blood pressure and also the heart rate. And that's how it controls high blood pressure. Beta blockers also help decrease cardiac workload because they are cardioselective beta blockers. And I think I've already covered this with you. Adding a beta blocker to an ACE inhibitor decreases the mortality rate and hospital admissions, and that's important for you to know. If your patient is unstable congestive heart failure, you should not administer a beta blocker because you can potentiate the problem. You can make it worse. Calcium channel blockers should be avoided with congestive heart failure. They've been shown to increase morbidity and mortality rate in patients with left ventricular problems and patients who have heart failure problems. So your calcium channel blockers would be verapamil, cardizem, nifedipine. Those medications need to be avoided in your CHF patients because they increase morbidity and mortality rates with left ventricular problems. And I know this was a pretty quick lecture this evening, and it was a fairly short chapter. These medications you've already had with your drug cards. So if you've not read the 7 pages in chapter 10, I encourage you to go ahead and do that now because I promise I did not cover everything mentioned in the chapter in this lecture. And I will see you at the next class day.